Welcome, good morning, good afternoon, and good evening, everyone. Welcome to the Patient Engagement Open Forum, session Making Digital Health and Data Accessible. My name is Elizabeth Priest. I'm a program manager for the Synergist and PFMD. I'm the lead manager for PFMD's digital health initiatives, and I will be guiding you through our session today. So if you're just joining us today, we have an exciting session planned for you as part of the Patient Engagement Open Forum occurring today and continuing with 2 more sessions on December 9th. The PE Open Forum is a series of online events co-organized by PFMD, EPF, and UPADI. We're a little bit unique in that there will always be an interactive element to the sessions where we ask for your input and advice as the audience to shape current, future, and ongoing initiatives in PE. In this session, we'll be hearing from 4 excellent speakers and then asking for your input on what we have discussed today in an insight gathering activity. Next slide. Before we get started, just some quick housekeeping. This is a Zoom webinar, so your microphones will be muted over the course of the session. However, please use the chat and Q&A functions to ask any questions and provide feedback. The session is recorded, and we will share both the recordings and the slides with you afterwards. We count on you to be engaged. Help us forge better programs by representing you and your stakeholder group in our interactive activities. Feel free to say hi in the chat and also let us know where you're located. Next slide. So for the rules today for the Q&A can be found at the bottom of your screen. We will try our best to answer the questions live. However, if we are unable to get to your question for any reason, we will answer all follow-up questions in the summary report from this session. Next slide. So as I mentioned, we have some very special speakers with us today who will be speaking more to digital health and data. Quickly, before they dive deeper into their individual sessions, we were hoping to do a quick introduction so you get to know them a little bit better. Sharon, actually, you're first here on my screen. I was wondering if maybe you could say a quick hello and let us know what your hopes and aspirations are for this session.
Great, thanks very much, and thanks for having me. I'm Sharon Terry. I'm the president and CEO of Genetic Alliance, and my hope is that this conversation and these kinds of conversations will actually change the ecosystem to help people who need us to stop talking and get the job done.
I love that. Get the job done. That's something that I think we need that attitude. Dawn.
Good morning. I'm Dawn Berry. I'm the president and co-founder here at Luna. The goal for the day is to share what we've built here in patient engagement, because we've been living and listening this problem for a long time. And I hope that engagement will be a gold standard, because not only is it the right thing to do, it will deliver the best research and discovery. So it's a must do. And as Sharon said, let's get it done.
Thank you so much for joining us, Dawn. I know you're joining us from San Diego too, so it's very early for you this morning.
Yes, if we get interrupted by Miramar Air Force Base, I apologize to all the attendees.
It'll just add to the ambiance now for these Zoom events. Thank you so much. Sarah, over to you. I think you're on mute.
I'm Sarah Krug, and my goal for today is to really ensure that we're unifying qualitative and quantitative data so that we're co-designing the future of healthcare for people rather than just the patient and their disease.
Thank you, Sarah. I think the co-designing piece will definitely be key. Veronica. Oh, Veronica, I think you're also muted.
Sorry. Hi, everyone, again. I'm really excited to be part of this session and the change it will create. I'm Veronica Popa. I am the digital patient engagement manager at Eurordis. I am also the chair of the MCT8 HDS Foundation. I believe that patients need to play a bigger role in addressing the issues that affect them. So we should do that. We should start from here. So I'm looking forward to discussing and finding solutions together.
Wonderful. It's really great to hear upfront from everyone kind of what you're looking forward to achieving today. And I know me personally, I'm very interested in hearing more from all of our speakers today, building on what we've heard this year in the open forum for digital health. But also I wanted to call attention to the fact that the feedback from the insight gathering activity will feed directly into the digital health initiatives at PFMD. And I would also like to point to the fact that this is one of the few all woman-led PE open forums that we've had this year. So I know if you're just joining us from our previous session about the youth engagement in medical devices, we had an all-woman-led team there too. And so following it up today for really kicking off our final event for 2021. Next slide, please. So it's really important to note that this session comes directly from your input as the audience, kind of following up on what we've already discussed this year at the Patient Engagement Open Forum. In April, we had a session called How to Connect Patients to Digital Health, where you told us there needs to be a digital data model designed with patients for patients. In June, we dug a little deeper into that. What makes a responsible data model? What is the value, the role for patients in the design, management, analysis? There were so many great ideas that came out of that session. And what we learned, though, that there seems to be a little bit of a disconnect between what we want to achieve, but how we can achieve it, how we would achieve it. So that leads us into today's session, where we're hoping to hear from some of the leaders in PE on digital data landscape, on the models that currently exist, what are some factors enabling this successful data management, and what we can look forward to in the future. As I mentioned before, we'll finish this session by examining the success factors of responsible participant-centered data management that are being brought up today, and seeing what others you believe should be included, and what potential challenges you have as the audience and roadblocks in achieving these. So next slide. Right before I hand over to Sharon and Dawn, I just want to say that we've been speaking a lot about data models since June, and I'm very excited to have you both here as speakers today, because I think the Genetic Alliance and the work that you're doing is actually acting upon some of these good practices. So it's really great to see this in practice already, and we're really looking forward to hearing more from you.
Great. If you can hand over the screen share, and Sharon will get started speaking.
Great. Thanks very much. It's wonderful to be able to be with you all, and I really appreciate the work that you are doing. So I'm going to speak to you today about something very concrete, very global, very dynamic, and that is the promise for engaging everyone responsibly. We call it PEER, powered by Luna, and you'll hear from both Dawn and I. Next slide. I come to this by way of having two children diagnosed in 1994 with a genetic condition and finding nothing available for them in terms of a treatment. Set to work about 2 months after they were diagnosed with my master's in religious studies, and discovered the gene and went on to create a biobank and registry, patent the gene so that we would make it freely available, and moved into clinical trials. I say all this not to be proud of what I did, but instead to say that right from 1995, 94, with no internet, we knew that people could actually be in the driver's seat. And we got a lot of requests to actually replicate this for other diseases. And so we moved on to Genetic Alliance, where about 20 years ago, I took over the CEO-ship. Genetic Alliance had been founded in 1986 and is a coalition of 10,000 organizations, 2,000 of which are advocacy groups. And we have many, many products. I'm only going to talk today about PEER, since I think this really unifies all of them. We really believe that people-driven research needed to be implemented and made real. And so for many, many years, I've been writing papers on it, believing too that I had to be able to speak the language of those who are in power, those who are making decisions, and really talk much more about not just checking the box, but instead seeing that participants are actually at the center and doing the driving. This led us to articulate some principles that Genetic Alliance has had all along. So we run a registry system, biobank system, et cetera, because there was a huge demand to replicate what I had done for PXE International, since it was the first lay-led registry. We established the Genetic Alliance Registry and Biobank in 2003. No one else was doing it and no one wanted to do it. We asked a lot of others, why don't you take this on? And there was no interest. Believing that communities are the drivers for registries and studies, we believe they're the best long-term stewards as well. Researchers retire, companies shift their interests and so forth, but we, the communities, never shift our interest. We're the best representatives of our members' needs. We believe that people must control access to their data, and that's been our belief for our 36 years. People must receive the results of their tests and studies. And basically, we can't have business as usual anymore. The biomedical industrial complex should be in service to those who need it. Why do we do this in terms of our method? We have too much in common and registries must be cross-conditioned. So from the start of our registry, it's been one database. People have comorbidities, there are common pathologies and pathways, and so we have always been cross-conditioned. We believe that data standards and quality are paramount, and Dawn will speak to some of this as well as to the privacy and security requirements that are critical. In our registry system, collaborative learning is enabled, so all the advocacy groups work with one another. The consortium is governed by the advocacy organizations, and Luna itself is owned by the people who share data. New business models are constantly emerging and are supported, and we believe this mechanism should be as easy as putting a PayPal button on a website. So from 2003 on, we established the Biobank Registry and IRB and used simple softwares like FileMaker Pro and Excel. We moved to a system called REDCap in 2008. We found it sorely lacking for a lot of the things that we needed to put people in the middle and not the researcher and not the community, but the community as a home, the person as the base unit, essentially. We won an innovation prize in a Shark Tank style competition, and that gave us the boost to actually create our own solution in 2014. But by 2019, we knew we could not keep up with the privacy laws in the world because this is a global solution, as well as we did not have the technical chutzpah to be able to do this. And so I'm going to turn this over to Luna because Luna is who we chose to partner with.
Thank you so much, Sharon. I come at this, having been a caregiver, but also someone who spent their whole career in health data and genomics. And even while my time at Illumina, got to collaborate with Sharon and really understand the problem. And what we built in response to the problem first starts, as Sharon says, with community. And why community? Because community is the source of truth. We look to each other for truth more and more. We don't look to experts, media, influencers. We find our truth amongst each other. But when we think about the technology we've had, it's largely been kind of chit-chat platforms that, as Sharon mentioned, haven't put GDPR and privacy laws in the forefront yet. And those have been coming at us fast and furious. But then we look at, in a non-people centered language, we look at research and industry and ask, what do they want? They want data now that's representative of people in the real world, not in a clinical setting, longitudinal, multimodal, ideally leaving that data stay put with people, and operating with these privacy laws on their side, and really getting to data that's much more representative. And so what we've determined here with the opportunity together is exactly the data that communities need to solve their problems. I believe people can be researchers, is precisely what industry wants. And can we challenge ourselves to provide that data to communities to establish answers in the clock speed they need, which is yesterday, while also providing a lens to that data for industry to solve other problems that take a longer clock speed. So as I mentioned in my intro, we've been listening to this for a long time. We understand what people want and even participated in many of these publications with Sharon while I was at Illumina. And I won't say this here because we all know this is what people want, but they haven't had a system to do it in a fair way that also blends the high science required to do next generation research. So in a very quick look at what we've built here, and know that we're lifting both sides. We believe when communities can answer their problems in a clock speed that meets their needs with data on their side, we can also solve industry's problems, and we lift both sides of this equation. So on the community side, what we offer is an opportunity for these groups to digitally assemble, to recruit people from different places, to invite them to share myriad data, which I'll go into, for them to view that data the same way data is gathered and explored by a well-funded researcher So can you. And then what's equally important there is to continuously provide insights back for engagement, but we'll also share a case study where the community is solving their own problems. And then when we think about the industry side, again, non-people-centered language, the opportunity to create better phenotype, the opportunity to recruit internationally to establish that scale, the opportunity to collect data, but leave it with the people, but allow it to be studied in the same way that they're used to. And then stay connected to people, because let's be really real here. We forget questions we need to ask. We want to recruit again. We need to stay connected to people, yet privacy protected. And let's all challenge ourselves to lean into those privacy laws, because they are hugely empowering to people. And if you do the technology right, they're not too hard to adhere to, which I'll go into later. So then at the intersection of these worlds, what we've built is an ability to aggregate, organize, structure, and make research ready a whole bunch of data, including the omics, everything from a DNA file you might have gotten from 23andMe to APIs with labs. We connect to the vast majority of health records, electronic health records, so they're easily connectable and pulling that data in. A wonderful survey innovation from off-the-shelf validated instruments to bespoke, longitudinal, privacy preserving. Sharon will go into one of those innovations, and wearable sensors, monitors, et cetera. So the real good slew of data here that allows communities to work with industry in a language that they speak, while empowering those groups to also access and make valuable that data. So it's a simple 1, 2, 3, starting with the platform, whether you want a next generation registry or you just want to do a study, this is a great place to gather people, to aggregate that data, and to study that data, to augment the data you collect with maybe some private or public data sets, to use preloaded tools like Tableau and other visualization and genomics tools, et cetera. Leave the data, stay put, create a data stream, don't create a database, and stay connected with people. The case study I'll share here, and I think Sharon's going to leverage a little bit later, is one that was discussed at Biogen's Investor Day. So this was an opportunity for Genetic Alliance and Luna to help Biogen recruit in KCNT1 derived epilepsy. The goal was 25 people. Of course, you have to operate internationally. At the time, no advocacy group existed. So as we all know, we've got folks on Facebook and in pediatric neurologist's office, no place to go. So in summary, what happened here is we opened the platform. Of course, we operate remote and digitally. We want to change that for how all studies are done. I'm in the platform, 200 parents with 115 children. So great representation here. Launched a patient-centered drug development meeting, leveraging the tools in Luna and Surface. What families want is quality of life, and what Biogen is focused on is seizure reduction. So let's focus on what those families want and really dig into this. We deployed community-driven innovation and Surface that parents were really, some were finding great ways to hack the day, including Botox and salivary glands to reduce drooling, allowing kids to sit up, make eye contact, and create a better quality of life. Same outcome with some durable medical pillows that parents were very successful with, in addition to tea that reduce constipation and thereby reduce seizures. So what you see here is a durable value of community solving their own problems. And now as a result of Genetic Alliance's work, we have a foundation that's off and running with other research opportunities. And now, again, challenging ourselves to work within this industry in a manner that meets our values. Biogen, in this opportunity, there's 300% enrollment. That's terrific for research. 2 weeks to get to that goal, 200% of data collection, and new collaborators along the way in terms of including the top pediatric neurologists. So I hope it's clear that you see value on both sides of this. You see stickiness on both sides of this, and truly representative research in this case study. Sharon, I'll turn it back over to you.
Yeah, so the case study that Dawn just gave you is one of many in which we have academics, industry, and advocacy working together. This example here is a project called I Hope Genetic Health, just announced on November 16th, where Illumina has donated $120 million to Genetic Alliance to allow us to enable whole genome sequencing for undiagnosed individuals, especially babies and children across the globe. emphasis on Africa, Latin America, South Asia, and so forth. And the point of this here is that all of what Dawn has just showed you, so that individuals, families, communities can have their data in one place where they can freely share it with researchers like Biogen and many other companies and academic groups can come to a workbench and use that data. And as she said, in a data stream rather than a database, so that the data can be gathered and collected over time. So we're very excited to have not only the sort of niche projects which we need to do in rare diseases, but also this global one, which we believe will catapult all of this forward.
GDPR, this is an international gathering, so I'll just say with GDPR, we determined as a platform that we're going to operate at the most stringent standard. There's a lot of groups that are really struggling with this alphabet soup, and it is a struggle. However, if you default to the most stringent standard, you can kind of get all the other ones. So we believe international representation is simply critical. We've operated from the beacon of GDPR. We don't think HIPAA is sufficient at all. We live in an age of re-identification. HIPAA was also based on de-identification and sharing that data or storing that data safely. We see over and over again that that's not happening. So we operate with GDPR not only as our beacon for the platform, so we manage it so that communities and researchers don't have to, meaning we bear the burden of the data controller role, but we also sit in the seat of, this is very empowering for people. If you remember back to what we know people want, GDPR answers that. And we believe people should control the use of their data. They should know where their data is being stored, and they should be able to understand what it's being used for, of course, and permission it for that use. And lastly, the right to be forgotten, simply put, the right to delete themselves. And so we've implemented all of this in the platform, again, because it's very empowering to people. It's what people want. And in an age of international research, it's what we must do. Sharon?
One of the things that we're really excited about is that we've actually created essentially a new way of working around how people actually can be heard. And I think that you're going to hear some more about this from the other speakers as well, that when people's needs are at the center, very different things occur. And Dawn gave the example of now we have some babies and children with KCNT1 actually sitting up so that they might learn to crawl, et cetera. So right now, the current methods like Delphi processes and focus groups and other things are too long, they're not iterative, and they really don't perform well in the real world. Participants are feeling ignored when research comes to them because their needs are not represented in that research. The endpoints aren't ones they recognize often, and it's very slow. In an age where we can get everything we want on our phone in our pocket, it doesn't seem to make any sense. And so we've created this system whereby we call it CDI, Community-Driven Innovation, and we identify, we use design principles, we measure what it is communities want and what they can do to improve themselves, and then iteratively they feed that back into the system. And all of this, because what Dawn has talked about, is very easy to use. You can set up a community in about an hour on the platform. You can deploy your first questionnaire the next day. We have our own IRB, and so you have IRB approval because the platform is already IRB approved. All of this is very, very fast. So this community-driven innovation is a set of methodologies. It comes from something called computational social choice techniques that drive at what is really underlying what somebody says, not just the superficial piece. This process, this science, has actually a long history in product research for companies like Microsoft and Google and so on. And they have used it to adapt, as we have all seen, so that they can do research and discovery quickly. We're simply taking that and a bunch of other things like anthropology and ethnography, et cetera, and bringing it into the health space so that we can have reliable snapshots of people's needs and priorities and even see how those change over time as we begin to meet those. And so communities can use this system on the Luna platform, again, setting it up in a matter of days. And we understand then how we can get tangible and solid discoveries that make a difference today to people. It has lots of gorgeous graphs, etc. This is simply just to show you we can go in many different cross sections, many different ways of looking at the community. You can go to the next one, Dawn. We can look at what does hierarchies and priorities and categories take into account, what happens when those shift, what's actually coming clear to us is what do people need and want, and this was one community, and we've done this for the WHO, and I'm saying we a lot. It's actually people at Luna who have invented this, and our communities have simply implemented it. So in summary, our principles essentially are that people control, manage, and share their data and share in the benefits. They keep a string on their data at all times, that people, communities, and IRBs, ethics teams, and so forth are the governors of this system that I've just showed you. So we have a collaborative governance. You can see the paper on the right, data sharing goals for nonprofit funders of clinical trials, that we set standards at the same time. We're simply not just talking, we're saying, here's what happens if we, the advocacy group funder, actually does make a decision about something in terms of, for example, data sharing, that we implement that even as we fund other entities. And that this be sustainable, we have to have a long tail iTunes model. This cannot be expensive, so to use Luna is free for the communities and the individuals, that the price that the cost for doing the research and the workbench be very, very low, that the data sharers actually own the system and receive shares and dividends in the company they own. The paper here at the bottom, database shares that transform research subjects into partners, is a critical paper on this effort that Dawn and I and others have written, and these will be available to you in the materials that you'll receive after the webinar. Thanks very much.
Thank you.
Thank you so much, Dawn and Sharon. I think that's fascinating on a lot of levels. And I know that sentence of what you said, create a data stream rather than a database, I think that's going to be definitely a highlight of this session moving forward. So great line there. And I'm going to pass it over then to Sarah, who will take us a little bit through what co-designing the future of healthcare with patients and their families looks like.
Sorry about that. Okay. You can go to the next slide. That'd be great. Thank you, Elizabeth. Okay, so it's an exciting time in healthcare where patients have shifted from being passive subjects to active partners in co-designing the future of healthcare. And there's been this transformational shift to truly amplify the voices of the experts by lived experience, the patients across healthcare, as we recognize that the life expertise of a patient with the disease, it's an invaluable resource that can help clarify a patient's priorities and needs long before we embark upon discovery. But it's important that we carve out safe spaces to also integrate the voices of patient populations that are typically not heard. And that's really been the focus of our work at the Health Collaboratory. So I'm Sarah Krug. I'm a cancer researcher by trade. I'm a patient advocate by choice. I lead two organizations as CEO of the Health Collaboratory, which is a global innovation hub that's focused on cultivating trust and advancing equity across healthcare by amplifying the voices of the patient, the care partner, and even the clinician in the co-design of healthcare innovation, whether it's research, education, technology. And then I'm also the executive director of Cancer 101, which is a patient advocacy organization that's focused on empowering patients and their families to navigate healthcare in partnership with their healthcare team. And if we can go to the next slide, please. So a person's story provided through the voice of the patient or the care partner, that's medicine's oldest diagnostic tool. And it's often one of the most overlooked places to find important clues and pieces of the healthcare puzzle that may not come up in a diagnostic. And we know that the life expertise of the patient can transform assumptions made, it can change health outcomes, it can even save lives. And I've worked across sectors from research and disease management at Sloan Kettering, to varying roles at Pfizer, from research to advocacy. And I now spend my time at the intersection of innovation, patient advocacy, and behavior science. And the lens that I've looked at patient data from each of those sectors, it's varied greatly. And that's why it's important for us to start unifying our efforts and insights. And it's wonderful to see the shift towards humanistic healthcare, with person-centered approaches as the holy grail, right? Instead of a cancer or diabetic patient, for example, it's a teacher with cancer or a mother of 3 with diabetes who's trying to make ends meet. It's taking the time to understand a person's story that goes beyond the symptoms they bring that patient to the doctor's office, right? So a human-centered approach can illuminate how a person became ill and the social challenges they faced in getting better. A person's story can offer missing links and context that can nourish empathy, prompting a shift in mindset from how do I treat this patient's disease to how do I help this person get better? What are their beliefs, their values, their expectations around incomes? What are their limitations and barriers? What do they enjoy doing? And when they're not at the doctor's office, and how can I help them do this better while managing their condition? And all of these insights can be gathered as we focus on piecing together that patient story, or that person's story, I should say. Next slide, please. So, again, there's been this remarkable evolution from paternalistic medicine to participatory medicine that evens out the power imbalance we sometimes see across healthcare, where we recognize, again, the importance and value of partnering with patients. And patients have access to more information and data than ever before, with our focus on health literacy and data sharing and plain language summaries and open notes, just to name a few. Patients are more connected. They're learning from one another. They're asking more questions. They're more empowered to explore options. But on the flip side, we live in an era of information overload, where it's not just access to data that patients want, but access to understanding of that data and what that means within the context of their lives. The needs of patients, their fears, their concerns, their comfort levels, their engagement levels, their preferences. They're not one size fits all, which means our approach to patient engagement really needs to be multimodal with personalized strategies put in place. And this is a sneak peek into an ecosystem that we've co-designed with patients, care partners, among others, in the community that's focused on helping them better understand their health data, with the goal of engaging people before, during, and after their illness. And the ecosystem is called Health Entangled, set to launch in early 2022. And it includes everything from translating lab values to understanding the world of genomics and genetics. And there's other projects here that you can take a look at. But this is, again, a snapshot of how we're really looking at helping people understand their health data over time. Next slide, please. So many of our programs originate with the barriers, the needs, the gaps that exist among patients, their families, but then we work with clinicians, hospitals, health systems to co-design these solutions as well, to ensure that we're also accounting for their barriers, their constraints, their workflows, and even their incentives to ensure alignment. And this is a schematic of how a few of our technologies are connected. So our learning preference barometer assesses how people take in and act upon information. And that feeds into our prescription to learn ecosystem, which is a health GPS that helps patients and caregivers navigate resources that are personalized based on their preferences and point in the journey, allowing us to further understand what are the information seeking and navigation behaviors longitudinally. And then, of course, Health Untangled, which I mentioned, which provides access to understanding of that data. And since our programs are integrated into the point of care, we also work with these stakeholders to develop KPIs and measures that are often tailored to accommodate system needs within a continuous loop, which allows us to identify issues early on and continuously improve our interventions and processes based on what we learn along the way. And so through customization, we're able to also target specific needs within particular populations. And if you can go to the next slide, please. So a lot of our work is also focused on understanding the impact of social, cultural, economic variation and patient understanding and preferences, and how that influences attitudes, behaviors, cascade of decisions. And we have a few programs that evaluate the patient-clinician interaction and the influences of real-world barriers on decision-making, and how that ultimately affects the overall treatment pathway. And the insights that we collect are often integrated into broader strategies and subsequent education, and also used to drive broader changes in guidelines and processes across systems. So we have a few system-wide programs that are also focused on alleviating health inequities in certain racial and ethnic groups. So at the Health Collaboratory, we use a participatory storytelling technique to allow for patients and their families to piece together and share their stories in a meaningful way, which provides an opportunity for co-production of the patient and care partner journey map. And we found that this technique dramatically improves the richness of the patient story, something that's often missing in a structured interview, for example, or even a PRO survey instrument. The patient stories allowed us to capture invaluable insights to understand the life of a patient, empathize with the impact a condition has on a person's life. But many across healthcare, they've struggled with how to turn these stories from words on a piece of paper to data that's actionable. And we've created a variety of tools to be able to translate the art of the patient story into a science, because at the end of the day, these patient stories, they're data with a soul. So we can collect this qualitative data, translate it into quantifiable data, but also combine it with other channels of data to bring in that 360 holistic view of the person affected by a condition and the impact it's having on the family, which can contribute to decision-making and ultimately improve health outcomes. So I'll give you a few examples of these tools. The Life Impact tool, it allows us to capture quantifiable data on how the patient's condition is impacting 10 different dimensions of their life, whether it's impact on the relationship with the partner, their family, their finances, their mental health. And it allows us to also establish a baseline and assess those changes over time, and then introduce interventions when barriers are identified. We've also used this to assess the impact on care partners. We also have the emotional journey barometer, which allows us to assess the various emotions and sentiments that patients and care partners experience across different phases of their disease, from the time they experience symptoms to long-term management, excuse me. And this allows us to better align the right resources and interventions at the right time, accounting really for that emotional readiness of that patient or that care partner to make a decision, for example. And this tool allows us to understand the influences on behavior and cascade of decisions so that we can reimagine what the ideal clinical encounter looks like to truly support informed decision-making. So, for example, we're currently working with a health system to integrate this tool at the point of care, where clinicians are using it in their decision-making model to determine at what point to engage patients with the right intervention. Patient Dr. Tango Score is another tool that was designed to assess the relationship between the patient and doctor across various domains. Data is de-identified can be shared with the clinician, and bidirectional trust is built into the tool to allow us to understand what type of interventions can be introduced to troubleshoot the issues that are identified. We can go to the next slide. So we have access to more information and data than ever before, but how we harness that data, connect it meaningfully with other data sources and use it to create actionable insights or translate it into the language of the stakeholder that you're interacting with to trigger some sort of action, that's the secret sauce. And oftentimes we're lured by the data that's easiest to measure and extract, but there are hidden gems that can bring a different dimension to those data sets if we start with the patient's story. And so, when we think about engaging patients today, who do we reach out to? We reach out to patient influencers who might be on social media, patient advocacy organizations. We aggregate data through online communities and forums. We engage volunteers through PFACs, which are all important channels. But how do we ensure that we're not leaving other patients behind? Many patients don't go online to share their healthcare experiences or even publicly admit they have a condition. Many may not be going to patient advocacy organizations on day one of diagnosis. So how do we ensure that these patients are part of our conversations as well, so that our data is not biased towards those that are most engaged with these channels? And as we think about engaging patients and care partners, it's important we move away from simply checking off the box that you've engaged a patient and really think about aligning the right patient for the right intervention. We need to ensure that there's diversity in race, ethnicity, age, gender identity, socioeconomic status, and so on. Patient data has never been more valuable. And while we often focus on how patient data is advancing scientific research and healthcare innovation, there's obviously a tremendous financial value as well. But again, oftentimes we're lured by the data that's easiest to obtain, but it's imperative that we have strategies in place to reach those that are harder to reach. And that's really been our focus at the Health Collaboratory, really amplifying the raw, diverse, and unfiltered voices of the patient and caregiver, who also potentially want to remain anonymous. And if we go to the next slide. So we created the patient Shark Tank to amplify the voices of the patient, the care partner in the design of healthcare innovation. and obtaining perspectives from diverse patients that are harder to reach, to ensure that, again, we're not biasing our data with the most engaged and or loudest patients, for example. So again, I mentioned that many living with an illness struggle with what to share with whom. They may be afraid of the consequences of disclosure or stigma, that they may just want to maintain their privacy. That doesn't mean they don't want to be part of co-designing the future of healthcare, which is why we've created safe spaces for them to contribute to the conversation without ever sharing any personal identifiable information or even leaving their home. We've engaged over 24,000 patients globally across conditions. Majority haven't interfaced with anyone in the healthcare ecosystem outside of their healthcare team. They're not going to conferences, they're not on social media. We have partnerships with trusted partners within the community, from places of worship to barbershops, to community clinics, just to name a few, to help us recruit these patients. And approximately 68% are from underrepresented groups. Patients and care partners are sometimes coached on how to reflect on their personal stories and experiences, since many don't realize they have a voice or a role to play in reshaping healthcare. And that's why, again, we've been focused on ensuring that they're part of the conversation. A standard methodology was co-designed with patients to allow for, again, both that quantitative and qualitative approach to collect insights and perspectives. We have a 12 domain scorecard that's used to provide structure to the assessment, while also allowing patients and care partners, obviously, to reflect on their individual perspectives. And the 12 domains distilled down into a 3-part score around engagement, value, and credibility. On these certifications and the standards, the standard methodology allows us to collect both a qualitative and quantitative approach to those patient caregiver insights over time. We've integrated the patient shark tank into programs at medical schools, health systems, pharmaceutical companies. For example, we've collaborated with various pharmaceutical companies to provide patient input into research design, starting with defining what the research question should be. We've used the patient shark tank to evaluate and redesign patient support services. We've partnered with a medical school on a year-long curriculum where we work to address gaps and develop innovations in primary care, where patients worked alongside clinicians, researchers, community workers to identify barriers and then co-design the solutions. We're also working with a few hospitals to develop a formal process for investigators to engage patients in research that goes beyond the traditional PFAC. What does PFAC stand for? Patient Family Advisory Council, which is often not reflective of the community that they serve. So not only have we worked with various organizations to bring in the voice of the patient and care partner through the patient shark tank, again, connecting them with those patients, but every one of the innovations that we've also co-designed with patients is run through the patient shark tank, which again allows us just continuously improve our innovations over time based on those diverse perspectives. You can go to the next slide, please. And we're still learning about patient preferences and how to best incorporate technologies into a person's life, with everything from smartphones and tablet apps, wearable health monitors and devices, skin patches, bodily fluid diagnostics, or even a device that's swallowed. We know that the use of technology provides a number of advantages, like the ability to collect data beyond the constraints of time and geography, and the potential to alleviate patient burden through less frequent visits, especially for those with limited mobility. Many patients also have a perception that more accurate data could potentially be collected because of the use of more objective data collection tools and potential for more responsive safety monitoring, for example. The thinking is, if you can now get a better glimpse into how I live my life, what I may be doing, could that potentially help improve my health outcome? But at the same time, it's important that we reach patients where they are, find ways to seamlessly integrate technologies into their daily life flow, rather than expect them to fit into our constrained workflows. And I often say that patient engagement, it goes hand in hand with clinician engagement. And this is where I often see organizations fail because they're either focused on one or the other within a team strategy. When it comes to technology, there's extensive skepticism as it relates to who's monitoring data. How is it being monitored? Technologies, it's outpacing security, privacy, and reliability. And that can have a major impact on trust, because oftentimes there's a lack of transparency into how data is being utilized. And transparency goes above and beyond tucking legalese that no one can understand into the terms and conditions and privacy policies that often require a magnifying glass to read. And so it's really important to ensure that Patients are part of the conversation every step of the way. And as we embark upon this path forward and explore how the digital world can be used to engage people, unifying qualitative and quantitative data to improve health outcomes, it's important for us to think about some of these things, including digital empathy, in how we're accounting for the person versus the patient, how we're developing different user interfaces tailored to specific patient groups, really thinking through diversity, inclusion, and equity strategies, and really thinking through like what problem are you trying to solve with the technology you're creating, and then obviously how are you protecting that data? And I'll conclude by saying, let's really think about meeting patients and their families where they are as we co-design the future of healthcare, recognizing that technology has boundless opportunities. Imagine a world where every person-centered innovation was truly co-designed with patients and their care partners. Thank you.
Thank you so much, Sarah. And actually, we'll leave the questions later once we get into our interactive activity. But I think it's really great hearing from you and understanding the flow, because it's a valuable and complementary story to what Dawn and Sharon presented. I think the data flow is critical and needed. And while our first presentation kind of focused more on the system that should be in service of the population, you're now speaking and empowering individuals to use that system and saying how to do it. So really nice story there with the building on of the value of that community. And as Dawn and Sharon mentioned, the community-driven innovation and problem solving. So without further ado, I'm going to pass it over to Veronica, who's going to speak a little bit more into health data sharing.
Thank you, Elizabeth. I really like how the presentation I'm about to give complements the previous two. So let's get started. Next slide, please. Why balance? When the organizers wrote to me and asked what revolutionary concepts I'd like to share with you today, it made me think, do we need revolutionary concepts, or do we already have all the tools and ideas we need in order to be able to share data in a sustainable, ethical, and responsible way at European level? I don't think we're missing any big ingredients. We just haven't found the right balance yet. Reaching balance, however, implies a deep understanding of all stakeholders' needs while addressing each one of them in its context. That is why there is no one single solution for health data sharing. Next slide, please. One size fits all approach can't be the solution for health data sharing because it leaves too many people behind. Patients are alike and yet different. In my experience, unless we're talking about overarching matters, patients' voices are not one loud, unique voice. It comes in all colors and shapes. Considering that consent to data sharing is and should always be a personal matter, I don't think we can afford to address only the voices that form the majority. To take full advantage of the power of health data, we need everyone engaged. Rare disease patients may have different approaches to research than non-rare disease patients, for example. Patients with genetic disorders might be more inclined to support research into genetic treatment than others. According to a patient consultations within the rare disease community, led by Rare Barometer, 97% of the responders are willing to share their data for research into new treatments, to improve research on diagnosis, and to understand mechanisms of the disease. However, only 51% were willing to allow sharing for research which is not related to the medical field. The solution for data sharing should be tailored to each individual's need and should be addressing people, not statistics and numbers. Next slide, please. Another reason would be time pressure. It takes on average 17 years for only 14% of new discoveries to enter clinical practice, while in the case of rare diseases, the situation is even worse. Some patients, rare disease patients, but not only, don't have that long. So in their case, there is always an implied sense of urgency, which may lead them to be more willing to share health data. Vulnerability versus loss of opportunity is a balance all patients need to consider. Patients' willingness to support scientific research and data sharing may somehow leave them vulnerable. The risk of identification in rare diseases is very high, and while that may not cause harm on its own, its implications might. Lunshoff et al. Suggests that intrusion on privacy can cause harm to social position and opportunities, to personal and family status, and to self-image and perception by others. However, re-identification may be useful for patients from the point of view of having access to individual level results, follow-up research, or incidental findings. Health data sharing is of strategic importance at the European level. It has the potential to create immense benefit for citizens and to accelerate research. But we need to keep in mind that the decision of sharing health data is and should remain a personal one. So, solutions need to be created in a granular manner, in a way that would address and answer individual needs and doubts. Next slide, please. Creating a governance framework that will allow data sharing needs to involve the active participation of patients and patients' organization in a meaningful way. Their presence within the governance structure, as well as the decision-making structure, will ensure the understanding of patients' perspective, experiences, but also the needs. With regards to secondary use of data, 5 core elements for responsible health data sharing have been identified. The first and one of the most important is respecting patients' preferences. Access to data needs to be transparent, protecting privacy and confidentiality, having patient and all relevant stakeholders co-defining and co-managing governance, and last but not least, providing feedback on the results and having incentives for researchers in order to share openly their research results regardless of outcome. Next slide, please. Being willing to share their health data doesn't mean that patients are willing to give up control over it. Even though that may sound contradictory, it really is not. As mentioned before, 97% of the responders of the rare disease community survey answered they would be willing to share their data. However, continuing the survey revealed that only 1% would prefer to have no control over who, how, and why their medical data is used. Overall, 80% of the responders want to have either full control of their data, 47%, or near full control of it, 33%. Next slide, please. The gap between people being willing to share their data with no control versus full or strong control may be related to the perceived risks associated to disclosure of personal data or health information. Starting with data being disclosed without consent to third parties, which is a concern for 50% of the responders, information being used in a different context, 47%, information being used without their knowledge, 35%, or becoming a victim of discrimination, 34%. It's worth noticing that within the general population, only 5% may fear becoming a victim of discrimination. Within the rare disease community, however, that perceived risk is almost 7 times higher. Next slide, please. People's willingness to keep control over their data may also have to do with the level of trust or lack of it patients have in different categories of stakeholders. According to the same survey, patients place most of their trust in the medical doctor involved in their care, 89%, less in patient organizations, 77%, and even less in insurance companies, 16%. As an overall conclusion, rare disease patients are very willing to share their health data, but in conditions that will allow them to keep control over it. Trust and perceived risks may influence their decisions. Next slide, please. Transparency and accountability are among the many pillars of trust. Patients want to know, they demand to know how their data is used, when, and by who. They want to know if their data has been misused, and if it has, they need to make sure that the responsible parties has held accountable. They need to know that the right mechanisms are in place for this not to happen again. Most of all, patients want to know the impact of their data. They want to know their data is helping, that the risk they have taken by sharing it is being rewarded. In a way, this is also the principle of the data altruism concept introduced by the Data Governance Act. Patients know and understand the value of data sharing, the value for themselves, but also for the society. However, they need to be able to trust the mechanism that promised them this value. Trust is a key element and one that can only be created organically. Without trust, the promise of potential benefit alone fades. Regarding protecting privacy and confidentiality, well, legally, there is no doubt these rights are stated and endorsed by European legislation. We live in times of some uncertainty, times when the digital world may represent sometimes as much potential as it does threat, times when assuming breach is a recommended strategy in systems protection. Patients may fear anything from third-party disclosure of their data without their approval, to data breach, to technically legal but sometimes unethical business deals, and not without cause. Protecting patients' privacy and confidentiality should be the golden, unbreakable rule. On the patient side, there is also an emerging need for education in regards to their rights as data owners, as well as the mechanisms which will allow them to defend these rights. Furthermore, as our world becomes more digital, a huge gap is emerging, the digital divide. To address this matter, measures need to be taken sooner rather than later, and digital literacy initiatives should be promoted. Next slide, please. Patients codifying and co-managing governance. Taking decisions for patients without patients is not sustainable and is not economically feasible either. There are lots of examples of initiatives that failed being created for patients without patients. It's time to learn from this mistake and make patients part of co-creating the system their health data will inhabit. Furthermore, co-managing governance will empower the patient's community by ensuring that their voices and wishes are heard and taken into account. But more than this, it would also ensure patients' continuous support of the initiative. Provided feedback and share results regardless of outcome. This last point actually incorporates two important messages. One refers to the returning data to medical trial participants. In this regard, the same consultation revealed that 99.7% of responders would like to be informed about the outcome of a data sharing project in which they participated. But this core element goes beyond that. Patients need to know how their data was useful, how this project may impact them directly, what the project can give them back. Giving back information to patients who were involved in a clinical trial would help empower them, strengthen their trust in the project, but perhaps even in a medical research in general. In this regard, a particular European project is worth mentioning. It's called Facilitate, Framework for Clinical Trial Participants' Data Reutilization for a Fully Transparent and Ethical Ecosystem. Its purpose is to find the best way for clinical trial participants' data to be returned to the patients and be reused in other research settings should the participants agree to allow it. During this 4 years project, Eurordis will bring the voice of patients in order to ensure the project aligns with patients' needs, requirements, and expectations. The second point addressed the matter of medical research being shared openly regardless of outcome. And in order to avoid making the same mistakes and spend huge amounts of money on research that has already been done, we need to incentivize researchers to share their results openly and without fear of their reputation being affected. Making mistakes is inevitable. The best we can is learn from them and allow others to do the same. Next slide, please. I'd like to close as I started by reiterating my call to balance through a few conclusions. Legal and ethical framework are essential in creating a trusted environment for secure, ethical, and responsible data sharing, but far from enough. Civil society at large need to play a bigger role in addressing these matters. Patients and patients' organizations need to be part of co-creating the system which will host their health data and co-manage governance in these systems. Last but not least, European and local legislators should make effort to promote cultural, technological, and infrastructural changes in order to support data sharing, as well as promote capacity building initiatives within the digital area. Next slide, please. And thank you very much for your attention.
Thank you very much, Veronica. I think your points to the individual needs, I think very much complement what we're discussing, and we look forward to discussing more and kind of doing a little bit of questions between the speakers that we've heard today. And also I encourage you, I see a lot of really great feedback and questions coming into the chat and into the Q&A. So please continue to use those avenues to engage with our speakers and with each other. So next, before we go into some questions for our speakers, I'd like to engage with you now in our insight gathering activity. So a little bit of an interaction here where we would like to get to know you better as the audience. So if you could please go to the next slide. We will be using GroupMap, which is a tool that we really like to use in the open forum to engage with the audience. It's a platform to collect insight and ideas. So we do ask you, you're going to need to open up two windows, one for the Zoom and one for the GroupMap, both using your web browser. We will be sharing the GroupMap link in the chat really quickly, and then you can use the instructions there to kind of go through the different steps and questions that we'll be addressing today. So next slide. Our first question here is going to just get to know you a little bit better so we can identify your stakeholder group and who you identify with. So if we can get that link shared in the chat here shortly. Perfect. There we are. So Diana, thank you very much. Just shared the link to go to the GroupMap. So we encourage everyone to click. It'll look a little bit like this, how she has it pulled up on her screen right now. Please take this opportunity to join. Really, really appreciate your input here. And like I said, your help really goes into shaping ongoing initiatives in digital health. So great. We see 20 participants have joined so far, 25. We have quite a few with us today, so we'll just give you a second to join. And please go ahead and select your appropriate stakeholder group. Diana, if you could take us over to the results so we can view the results while it's being filled out here. All right. So it looks like we have majority here, pharmaceutical companies, but then we have quite a few patients, patient organizations, caregivers, researchers, and other, and healthcare professionals with us today. That's great. I see that we have about half who have answered the question of the people that are on the GroupMap. So I'll just give you a little bit longer to fill this out. Wonderful. Medical technology companies, welcome. Happy to have you. So it looks like today we really have a majority of patient organizations, caregivers representing the participant or patient community, as well as a big representation from our pharmaceutical companies or industry. And it's great to see research as well being so high up there. So definitely continue to fill that out. Well, we are going to move on then to our first question for you today. We discussed some of these success factors today of what really drives responsible, participant-centric, accessible data management. We have a couple examples in here from what was discussed today. So going in and seeing people must control their own data and drive the relevant research as an example. We would love for you to come in and please add in more here. There, you can click that plus button. You see Diana is hovering over. Add in your ideas of what you think is a success factor. What else are we missing? What do you think is a key success factor for management and governance of digital data? What do you think is an advocacy organization specific success factor? So for example, we're saying incorporating and having a role for these new advocacy models, as well as there's room for specific success factors for other stakeholders and for individuals. And we do encourage you, as well as you're going through this and filling it out, please go ahead and feel free to like, and if you see an idea that's already there, you can click that thumbs up and you can go ahead and like it. So really great seeing these come into the group already. So then I'm going to invite our speakers to come back on and turn your cameras back on and unmute yourself here so we can have a little bit of a interactive session while the audience and participants are going through and filling in some of these key success factors. One of the things that I'd like to touch on, because Veronica kind of mentioned it as she was going through towards the end of her presentation, was that about the need for privacy regulations. And so I think it kind of piggybacks off of some of the things that Sharon, you and Dawn mentioned. So how do you feel about embracing these varied and complex privacy regulations around the globe? And how do you feel like they impact research? So I'm gonna turn it over to Dawn first.
Sure. And as I think I mentioned, first of all, all of us here have framed the problem. We know what has chased people away from participating research. And one of the factors is lack of privacy and concern on how the data is going on to be used. So number one, we need people to be partners in research. To do that, we need to honor their values, wants, and desires, privacy being one. So that's why we always say, we like GDPR. I mean, we've operated at the state and federal level, showing up while other, companies have brought tomatoes, to throw at those lawmakers. We think it's hugely empowering for people to be privacy protected while they participate in research. And then on the research side, if we can honor that, perhaps the data will be more robust, the cohort will be bigger, the data will be more representative, et cetera. So that's all to say, we lean right into it. We operate at the highest standard because we think it's best for people and best for research. And I would say, just as a built technology, we show up to both the communities and the researchers saying, we bear the burden of the GDPR data controller role so that you can drop in on the data and bear the burden of the lighter role, which is the GDPR data processor. Sharon?
Yeah, I would thoroughly agree with that we've embraced all of these regulations. And in fact, what we built was prior to GDPR, and actually when GDPR was published, lo and behold, we were exactly in line and even beyond what it required. So we're excited to see these grow all over the world. And Luna actually has a person who tracks all this and makes sure that everything that we're doing is compliant and beyond. So we're quite happy with them. And we believe, as Dawn said, that it enables research. It doesn't disable research the way many people have been terrified of it.
Sharon just reminded me, we have the CIO from Thermo Fisher, we have the CIO from Illumina, and their stance is you cannot retrofit privacy. You need privacy as code. You need privacy by design. It's very, very hard to retrofit privacy.
Thank you so much. Veronica, anything you'd like to add from that? So that's something that you touched upon in your presentation as well.
Well, I must agree with Dawn. Legislation like GDPR is very necessary, and considering the current environment, digital environment, is absolutely necessary to build trust. However, as I mentioned before, there is a need for patients and citizens in general to know their rights, because we are noticing that people don't actually know what their rights in regards to their data are, and they don't have the tools to defend these rights. So legislation is just one step, one piece of the puzzle. We need to go forward and actually make people learn their rights, have them embrace them and know how to defend them. Because otherwise just legislation is from the top and it's very high.
And I would add to that, and then in concert with organizations like Eurotis doing such a great job at educating, then building systems like the one that we've built that allow that to be seamless and easy, because as Veronica knows well, the parent of a child with a condition, it's not a lot of time to do the kind of study and work that we need to do as parents. And so instead, just like we are using various systems in our day-to-day life, like finding a car to drive us somewhere or getting music off the internet, we're trying and have embedded all of these principles into a platform that makes it easy for the person to then just relax and get the work done that they need so that they are actually making a difference in the lives of their children.
And I'll say, because this is a working group and an action-oriented group of people, perhaps we want to spin up, the top 5 to 10 questions that an individual should ask when approached with the opportunity to share their data to advance research. What are those 3 to 5 things they should look for in a technology provider? I would be happy to contribute to something like that.
Very interesting point, Don. I think that's great. And I have one more question for you, but before I do that, I want to turn it over to Sarah to see if you have anything to add to that discussion.
No, I was just going to say that, trust takes years to build, seconds to break, and forever to repair. And, this goes hand in hand with, I think Nicholas asked a question about an experience that he had with another online platform that would potentially influence his decision to potentially interact with a future platform. And so it's important for us to recognize that one bad seed can also potentially ruin it for others. And how do we ensure that we're collectively moving the needle as we start to put in place some of these privacy and privacy regulations? So I love the fact that Sharon and Don mentioned that that they're implementing regulations of GDPR across the board, for example, or the strictest regulation, even though it might not be required. And I think that that's something that we should all potentially try to attain, recognizing that, let's say in New York, for example, where we are, we might not necessarily be required to implement some of those regulations, but it's something that we should try to help build that trust over time and ensure that patients will want to potentially engage over time.
Yeah, and Sarah just said a key thing, and I'm sorry, I'm keep jumping in on this, but that we not ask the people to consider us trustworthy. So we not put the burden on the people. There's already so much burden. And instead that we are trustworthy and look at how do we become trustworthy, not asking you to trust us. And further, I think that we really need to be looking at what does it mean to be open and transparent so that trust is not even an issue. I mean, if most of us said, do you trust Facebook? No. Do you trust your electronic health record to be accurate? No. Do you still use those? Yes, because they're convenient. Do you trust Amazon? No, but I use it because it's convenient. And so instead of asking for trust, I think we need to ask for transparency, which these laws are essentially demanding from us.
Absolutely. So Sharon, my tagline or my motto is that transparency is the most disruptive innovation of the 21st century. And people interpret the term transparency in very different ways, but simply put, it's just, it really, we need a design for transparency, design for trustworthiness, but yeah.
I love this discussion that has turned to transparency, because I think in the last patient engagement open forum we had in June, it came up a lot about the need for transparency. So I was just going to turn it over to you guys and say, what is an example of transparency? What are you doing? What is a success factor for transparency look like? What do you consider being good transparency?
Well, I'll jump in and say, I think that all of the operations, motivations, principles, governance, et cetera, has to be published and publicly available. And so we've done all of that. I put in the chat that, in fact, somebody asked about, well, something like patients like me, for example, got sold to the Chinese and then to a healthcare payer company. The platform, and Dawn can speak to this better than I, that we've partnered with Luna on, in fact, is owned by the people who share their data. And so having something like the Securities and Exchange Commission of the United States oversee a platform, Dawn can tell you is rigorous and onerous, and something that they've opted for. Dawn, you probably can add to that with more eloquence than I.
And if I can multitask, I'll find the author's copy of that Nature Biotech article. But it's still early days here, but how we approached, and again, to Nicholas's point, we looked at the past and said, what's gone wrong? And we said, okay, how do we fix it? And how do we have an innovative sort of eye to transparency? And what we heard from people, it's transparency and oversight, specifically in the business model, how my data is being used. And if you get acquired, can somebody else decide, if I get hit by a bus, can somebody come in and change all the reasons why you shared your data? And, there's a lot of historical mistrust with people sharing their data with a medical establishment. And all of a sudden, again, sorry for being crass, but, gay gene research is being done or extreme inbreeding, that wasn't the intent by which they shared their data. They shared it to advance medical science. So anyway, what we did was approach the Securities and Exchange Commission and saying, look, data is valuable. It will create value in the form of interventions. And we want to treat it as currency by which people can acquire shares of ownership in the platform. And they qualified us. So we modeled it just as a small public company. And what that delivers is the opportunity for the people to take that shares of ownership to create a durable transaction with their data, and a transaction being a promise that's overseen by a third-party agency. So as Sharon said, you don't have to trust us. You can go on the SEC website. It's a little dull and long and boring, but you can see everything we're doing, and we bear the burden of reporting on that, et cetera. So that's how we've taken the burden off of people to decide if we're trustworthy or not. We've just put it all out there and asked for a federal body to oversee our promise. And if anything should ever happen to the ownership of the company, you can't change that. You would have to ask everybody to opt in again. So Nicholas, I think that answers the question I was going to email with you about. We're still early days. We launched the platform in 2019, but this is what we're hearing back in terms of the response to why we did that and it's established. And again, I'll chat the Nature Biotech link so you could check it out. And please let us know what we should do better, because we're here for the problem.
Thank you so much, Dawn. So very quickly, I'm just going to look at the results that we've put into the group map so far. So all of these have been liked, and now it is sorted by the number of likes. So you can see from our audience here, we see some key success factors being making the policies accessible, easy to understand, co-designed, stakeholders recognizing people as partners, which I think that was one of your original ones, Sharon, as well. We see supporting digital health literacy and empowering individuals to get involved. I wanted to, before we move on to the next section, which is the challenges, which we'll get in here in a second, I would like to see if anyone has anything to speak to digital health literacy, because I think this is something that really comes up very often in kind of the role of the patient organization in digital health literacy. So Sarah, I feel like you might be good here to support this with all the work that you're doing with Health Untangled and getting those into the conversation.
No, I think it really starts with understanding a patient's comfort level, caregiver's comfort level with interacting with different types of technologies, recognizing that it might not be one size fits all. We've had patients also assess through our patient Shark Tank terms and conditions of certain technologies. And over 90% didn't understand the terminology within some of those terms and conditions. And once we actually took the time to explain it, majority were not comfortable with some of the terms and conditions, and kind of started to think twice about potentially engaging with that technology. So aside from comfort level and engaging with the technology, it's understanding how the data will be collected, protected, shared, and whether they're comfortable with some of those elements is an important piece of the puzzle. Recognizing that, again, some people may also interact with technology, go online to share, look up information about their health condition, but they may never interact with a app on their phone that's related to their healthcare. We actually do a love-hate relationship with technology assessment, where we look to understand how they're potentially using technology in different ways, recognizing that you might use your technology in day-to-day life, but may not necessarily want to use it for healthcare. And so it's just important for us to personalize our strategies, recognizing that, again, it's not going to be one size fits all. It's not just about access to the internet, which I think oftentimes we equate tech literacy with. It really goes above and beyond that. But yeah, I could talk about this topic all day long.
Thank you so much, Sarah. So while we're on the topic of advocacy organizations, I did want to put Sharon, you back into the mix here, because you said something really interesting yesterday in our pre-session alignment, was that you felt like the future of advocacy organizations was going to change, that things were changing. And so I was interested in hearing a little bit more about your thoughts on that and what inclusion of these, organizations or entities will look like in the future.
Great, thanks very much. Yeah, so I've been in this arena since 1994, as I said, and I now have staff who are younger than that, and it's astounding. But basically, the first day that I stood up at a big, NORD meeting or even a Eurordis meeting early then and said, we advocacy groups need to be driving research, I actually was derided and asked to leave one of the groups because they said, no, this is not the role of advocacy groups. Now we know, here we are, all of us are doing research or at least trying to promote it. And so I think we're seeing another shift. And I think that is that the brick and mortar big, creating an NGO and all the heavy lifting is not going to continue. That's going to be too onerous for most groups with things like, I hope, and this really big long tail of people who are being diagnosed with conditions that have 4 people in the world. There will not be advocacy organizations the way we know them. And so what I see is that we're shifting toward online support communities, local on the ground grassroots communities again. And what I want to see actually is that we don't need to have all the encumbrances of putting together boards of directors and building, financial accountability systems and so forth. But instead, the people can organize in ways that really meet their needs, the way we have for other things, around our kids' sports, around our families' needs with regard to senility and dementia and so forth, that we stop being needed the way we were needed, but instead find ways to actually be engaged in research, because every single person has the right and the ability to participate and to coordinate and to come together in mini cartels to get done what needs to be done for various communities. We're working in faith communities, in environmental communities, in Black Lives Matters communities, because that's where people eat, live, work, play, and pray. And that's where they want this done, integrated into their lives. And they don't want to Sarah's point, find an advocacy group or, figure out how they can belong to just one thing and not another. We all just want to have our lives integrated. And so I see a big movement in that regard. It's going to take another 20 years to get there. I won't be sitting in this seat, but it will be, I think, something that will really enliven and make much more possible the kinds of research we want to see as we go forward.
Thank you so much, Sharon. So I am going to ask the audience.
Sorry.
Yes, just 1 second, Veronica, and I will get right to you. While you're speaking, I would like the audience, if possible, to go to the third question, just to let them know that then we have this last group map question, which is all about blocking you from achieving the success factor. So what's a challenge for you in doing this, whether that's at the management and governance level, at the advocacy organization level, other stakeholders, or if you're an individual participant, individual patient. We are going to switch over then to the conclusions here shortly. Veronica, I'm going to turn over to you, and then we can move on to kind of wrap up the session, just being mindful of the time, unfortunately, because I'm loving this conversation. But the group map will remain open until December 17th. So please, I would encourage you, please go in here, please continue to add in things, to like things, and we will leave it open until the 17th, so a week from this Friday. And we will then take that information and put it into a summary report to email back to all of the participants and registrants for this session. Veronica, over to you.
I was just going to build on what Sarah said before. I'm sorry, I wasn't quick enough before the change of subject, mostly on the health literacy part, because right now with the apps and everything, health data and data, so the border between the two gets very fuzzy. So all kind of data or general kind of data may be considered health data. Health data is not restricted anymore to hospitals or medical professionals. The same way as personal data is not restricted to social security number, name or address. So the borders between these kind of categories of information is getting very, very fuzzy. So maybe we should talk generally about digital literacy and not specifically about health literacy, because there are a lot of health apps that are used by people who are not patients, but they gather health data. So we should be a bit more inclusive when talking about literacy, digital literacy. That was just my point.
Great, thank you so much, Veronica. No, great point here, because I know that digital literacy and health literacy is a comment that comes up a lot. It was one of the top voted areas for advocacy organizations, so it's really great to touch upon that today. If we can switch back to then our slides, Diana. So thank you very much. As I mentioned, the group map will remain open. Please continue to go there. I just want to thank the audience, thank the panelists, thank all of you speakers for being here today, for speaking a little bit more to this. The Patient Engagement Open Forum is an ongoing forum where we want to bring together all of our stakeholders. We will continue into 2022 this discussion on digital health. And we look forward to incorporating the feedback that we received today. Next slide. And I just want to take a quick second to thank, really thank the speakers for being with us and the participants as well. So please go through. We have a very quick survey at the end of this. Tell us how we can improve, what we can do better. And then we look forward to you joining us on Thursday as well. We have 2 more sessions for you. It'll be one on patient engagement needs and platform trials, and then our patient engagement open forum closing session of 2021. We'll go back, look at the year in review and all of the progress that we've made to date. I'm just gonna give a quick opportunity here for our speakers to add anything in, any other comments or before we wrap this up. Wonderful. Thank you all so much. Thank you for joining us today, and we look forward to seeing you at the Patient Engagement Open Forum on Thursday.
Thank you.
Thank you. Have a great evening.
Everyone. Bye-bye.
Bye.